John made me promise not to talk about too much economics. I want to begin by thanking you, our Elder Cardinal, for welcoming us and your ancestors for caring for this land on Treaty 8 territory. Visiting from land cared for by the Musqueam, Squamish, and Tsleil-Waututh people. Very grateful to be here. It's beautiful. I'm visiting from Vancouver, and I'm really grateful for being able to come visit and talk to you about some of the metrics that I think are really important in the conversations we've had today about improving health equity for rural, remote, and Indigenous communities. My appointment at SFU is in the Faculty of Health Sciences, and I'm also at UBC. I'm an evaluation lead in the Department of Emergency Medicine, and I work in a unit that is becoming a center called the UBC Digital Emergency Medicine. We specialize in digital health and AI. I'm going to define my favorite metrics 3 ways, and they really are different buckets of defining equity. The first is equitable access, and I'm going to talk about shifting the distribution of access. That's relatively easy to measure, and I'll show you some measurements that we've done for the RTVS pathways. How's my volume here? I'm a little louder. Okay, thanks. I'm quiet. The second one is about the distribution of financial protection, and that's the healthcare system's obligation to protect patients from the high cost of illness. That's universal and a core objective of healthcare systems. And then the last one is about equity defined by outcomes from healthcare. And I pointed out the rurality index. That's the one metrics we don't have that we need. And I hope I can convince you of that. I'll start by talking about the easy to measure one, equitable access. We've got 2 quotes here from, these are 811 linked physician service users that were interviewed saying, on the left is the rural person saying, well, I live in a rural community, we've got no real taxi service here and you're just kind of stuck, so being able to access over the phone immediately is really reassuring, whereas the counterpart is the urban participant we interviewed that mentioned that they would just get an Uber. They had to wait so long on the phone to get somebody to talk to. So it's really different. We all know that. My work with Ray and the incredible collaboration for behind the real-time virtual support unit is made possible because there's agreement. We all know what equity means, and we're all able to kind of define it and measure it. So we think rural, remote, and Indigenous communities is a great way to define it. We also agreed on the use of the Canadian Index of Multiple Deprivation. That's the CIMD, and that's an index. And I don't think it's the best, you'll hear soon, but we agreed to use it. And then also we think income is a good measure of the distribution of equity. And we've got these fantastic policies and mandates guiding us forward. Learning health systems governance, which is critical for us to be able to look back and fail forward. And we've got rapid access to province-wide linked administrative data, which isn't perfect, but it's also really powerful when you can get everyone to agree to look at it and to make decisions based on it. In a infographic, there's 9 pathways for the real-time virtual support unit. It was a pandemic responsive product of Ray Markham's career work. It came in 2020, the JSC came together and thought of a way to keep emergency departments safe. So there's quite a few pathways. Some of them are client-facing that patients can access directly. Others are to support primary care, team-based integration, and then peer-to-peer support. That's the picture you see there of Bryden Blacklaws. He's a really cherished Rudy physician. Rudy's the name of the pathway for the rural urgent doctor and assistants. And they've all got cute names. I'll try to not use their names and use a description of what they do. Right there you can see the Rudy doctor on the iPad phoning in a First Nations nursing station and giving support to peers in the community there in rural areas. And the 2 pathways that have been around long enough are Rudy and then that I just mentioned, or peer-to-peer support, as well as the HealthLink BC 811 physician services. And I know Alberta has an 811 system that's very comparable, so really brought some examples from that one as well. And then the First Nations Virtual Doctor of the Day and First Nations Virtual Substance Use programs came together at the start of the pandemic. So the access to rural areas is really easy to measure with incentives that have been developed to deliver care to the communities that Ray alluded to. The most heavily incentivized are the RSAA communities, and we can measure how many were supported with these services with the administrative data, and note that of the 143 communities supported by the RUDI pathway, that's one of the most commonly used, highest number of encounters, better data. That's why I'm sort of leaning on these ones. 71% are RSAA communities, and we've got upwards of 90% for some of those virtual care pathways. I'll note the new one that just came up in 2022 was the Virtual Emergency Room Rural Assist, or VERA, pathway, where they're offering MRP coverage in these rural communities. And they've got over 90% of the communities being the most heavily subsidized. So lots of metrics to measure that we're getting to the edges, but we can also look at how we can shift the distribution to the parts of the population that you want to reach. And we've got the Canadian Index of Multiple Deprivation built into many administrative data sets now. It's comprised of 4 domains, and the one that I want to talk about with the minimal amount of time I have to get into this, and I don't want to bore you either, is the one on the bottom right. It's the situational vulnerability domain. It's a composite measure of education, income, and many things that we see being reflective of rural populations as an aggregate, but obviously not the best. But what we can see with the solid curves on the right and the upward facing solid curves is a slope index of inequality reaching the most disadvantaged quintile when you compare that with the dashed line, which is the overall general for the population. You could think if you were to invest a certain amount in a program to shift that distribution, you can weigh out the trade-offs of what you're getting back for what you invest in equity. So this is exciting, and we like the CIMD, and we are using it to monitor changes over time. You can see a 5-year interval here. So we've done, like Dr. Bourgeau recommended, we've looked forward 5 years and learned that we're not seeing much of a shift over the 5 years for this pathway. They are reaching rural and reaching rural, but we can disaggregate by different groups, and that's interesting. I'm going to move to the next bucket of financial protection. So it's really important to be looking at healthcare costs, says The Economist, but having a good comprehensive language so we're all looking at the same groupings and we don't forget some or shine a spotlight on some. This quote comes from Heidi, the 811 linked physician service pathway patient who was recommended that I do go to the emergency department. That's a big decision that you don't want to. You got to drive, and sometimes you can't drive because there's fires. So this is where that pathway adds in the context. So when we look at costs from the healthcare system's perspective, we can do that easily with most administrative data, and then we can add pieces on like the cost of program development, recruitment and retention costs, virtual care provision costs, and we would do like a bottom-up costing approach. Something that's not as easily linked is the transport data by air and ground ambulances, which they should be, and I'm going to advocate and say we need to look at everything and explain why we didn't look at something so we're all speaking the same language. I'm going to give you an example of what we can do with the cost data. This is for that 811 physician services. So a nurse staffs the 811 telephone line, and most of the advice they give is for the patients to seek care immediately. They can't give medical advice. So then the Heidi program was brought in to provide virtual physician services to hopefully reduce ED visits because of all the people being directed there by the nurse. And what you see here is a Sankey diagram showing that what happened after the physician saw the calls that were referred to them, and the small minority are directed to ED, and it's usually for a very good reason. So it's like a pre-hospital triage type system. And without getting into the methods too much, what I've got here in peer review is an article using an interrupted time series methodology, and we drew the right comparisons. That's also something very important, is to make sure you're comparing competing policy alternatives well. And we were able to demonstrate that, in fact, with evidence from the data, that the program was attributable to the ED reductions, emergency department visit reductions were attributable to the introduction of the program, and increased primary care visits in the community. We also looked at all the healthcare costs over a year, and we found that after a year of that comprehensive account of healthcare costs, that they were neutral. If I had a laser pointer, I'd point at the largest pink line across the bottom that crosses that dotted zero line. That means there's no additional cost, and it's a neutral introduction to the program. So it's very, very good evidence that the program's doing what we're hoping it does, and that there's things that are happening like costs for going to primary care increased by patients. So that's not the best one, but they do need to do the follow-up that's recommended, and that's the other aspect I was going to talk about. Patient and family paid medical travel is obviously an issue for rural health, but it can be quite a significant cost contributor, and we call this cost sharing, like how much is offset by the patients and family, how much do they pay for their time, for lost productivity, for paid or unpaid work, how much do they pay for informal caregiving when they need to have someone attend with them. And out-of-pocket is just related to the fuel and maintenance of a car, and usually sometimes accommodations overnight. And if you're living in Bella Coola, you might run into one of these roadblocks that cost you extra time. In our research group, we have a fancy piece of software called GEF. It stands for Geospatial Economic Outcomes Framework for Equity. Another cute name. This is a software that can calculate road distance traveled and look at the distance to clinics. And the dots you see on this map are all the emergency departments in BC, and you can see the heat map shows the greatest distance to travel to get those emergency departments. What we can do with that is we can get another distribution, and this is the distribution of financial protection, and we can draw a line for the threshold and say this is how we can count incidences of financial hardship, and that would be the one other metric that I think is my favorite. The WHO defines the incidence of financial hardship threshold at 40%. And that is a proportion of the amount patients have to pay out of pocket versus how much they have available after paying the basic necessities of life. So that would mean like rent and shelter and food. So some patients on the lowest income quintile on the right are paying over 100% of what they have available for a single visit to an emergency department. So that would be something that you want to keep an eye on and be able to hopefully mitigate. We've used the GEF calculator and looked at patient and family costs for RTVS this year, and in our 5-year report, we've estimated that $34 million have been retained in patients' pockets over the past 5 years from this network of virtual services from the past 5 years, and that reduced the cumulatively over 6,000 incidences of financial hardship in BC. That's the type of travel that was averted to the program. So really we can do these great things with the data, and there's some things that we can't do with the data and that we should be able to do, and that is to be able to look at it from a different perspective, and that would be the non-Western perspective, namely, the CIHR grant to go and learn a little bit more about this, because learning is definitely what we need to do. And in fact, tomorrow I'm headed to Wet'suwet'en territory to listen to the elders and bring a couple students up who specialize in computer science to figure out what sort of things we can learn from the medicine wheel. So another favorite metric coming up. With my last minute, I'd like to comment on how another thing's missing, the rurality index. So we don't have medicine wheel metrics, we don't have the rurality index yet. And a quote here comes from a First Nations Virtual Doctor of the Day client. That's one of those pathways, client-facing, that is run specifically with cultural safety in mind. And I just want to note, since we're talking about the Truth and Reconciliation Call to Action 23 about how representation of Indigenous physicians, that 35% of this pathway staff are Indigenous, and they track that and report it to us every year. So that's very nice. And the quote from the patient that used this said, I have not felt that respected, supported, and understood from anyone in the medical industry in a very long time. She made our difficult situations so much easier to deal with. We both cried with relief after we got off the phone because we were provided easy to follow, holistic plan, and felt like we were heard. And that's something that rurality indices don't really capture. Cultural safety is one of them. The distribution of outcomes, after a Heidi physician, here's our Sankey diagram again, after a Heidi physician tells some patients to go to ED, we can look at the data and see if they actually did, and most do. But in the bottom red line, there's a curve reaching up to no services recorded. Some people don't go to the ED even though a physician told them they need to, and that's where we're very concerned about the distribution of outcomes. Because if we use machine learning, I'll keep it quick, we can identify the over 300 reasons why people don't attend, but rurality is the top one. And then in there are Road BC events that comes out as a concordance predictor. And you see a heat map here with cool colors corresponding to less concordance or more discordance with the physician's recommendation, and then the warmer colors around the urban areas saying, that show that the distribution of outcomes is also inequitable. So in summary, 5 favorite metrics: slope index of inequality, resource utilizations and costs, patient-paid family medical costs, travel costs, incidences of financial hardship, and the distribution of outcomes with a custom-made rurality index that maybe includes medicine wheel metrics. Who knows, but I have a lot of gratitude for the Learning Health System partners and my folks at Digital Emergency Medicine. My Learning Health System mentor, Kendall Ho, who's not here today, but has been really helpful in helping me not speak economics so much and learn how to speak policy. And thank you for listening.